Good evening and welcome everybody to this second of my series Inside the Expert's Mind, brought to you from Cleveland Clinic, London. Tonight I'm delighted to tell you all that I persuaded my friend and colleague, Mr. Andrew Jenkinson, to join us. He is a consultant upper GI and bariatric surgeon at University College London Hospital, and he's also clinical lead for bariatric surgery here at Cleveland Clinic, London. And he's also a prize-winning, or soon-to-be prize-winning author, and has great expertise in the subject of bariatrics and weight loss science and medicine. Can I have my first slide, please? So here at Cleveland Clinic around the world and also here in London, we're very particular about the way that we are here to look after our patients and also take care of our carers. And our values shown in purple there are quality and safety, teamwork, empathy, inclusion, integrity, and innovation. And our mission is to care for life, researching for health, and educating those who serve. Can I have the next slide, please? So as I say, tonight we're going to be chatting to Mr. Andrew Jenkinson, and I'm going to start the meeting now. If we can go take the slides away, and we will continue our fireside chat, unfortunately without the fire. So Andrew, great to have you on the webinar. Tell us a little bit about yourself. Tell us about your childhood, where you were brought up, and tell us what made you want to be a surgeon.
So thanks, Richard. Pleasure to be invited, actually, honour to be invited. So I don't come from a family of doctors. I was the first doctor in the family who applied for medical school. My father's an aeronautical engineer. His father was an electrical engineer, and we come from an ancestral family of Yorkshire fishermen. I was brought up in Loughborough, where my dad was at university lecturing in the Midlands, and went to a pretty standard comprehensive school, which I think sort of was a little bit like the school of life. I learned some good stuff there to stand me in good stead for adult life. My mother tells me that even as a youngster, I was drawing, figures of humans with all the organs in the right place, so the lungs, heart, and kidneys and things. So I obviously had some sort of interest in our insides or human anatomy. I remember when the time came to apply for university, I was seriously considering astrophysics, but then on the last minute decided to do medicine. I just thought it would be maybe a little bit more interesting, more interaction with people, and be able to help people as well. So got into medical school. Then decided that I wanted to be a doctor in Africa when I qualified. So I took a sabbatical year during medical school, took a year out and worked in Zambia for a year, where I did a lot of vaccination clinics, lots of adventurous stuff like, going across crocodile-infested waters in very unstable canoes to get to people who needed a delivery. So I did a lot of obstetrics there, probably delivered about 100 babies. And it was fantastic. But actually, when I got back to the UK and I went into the operating theatre in the UK for the first time, that's what sort of made my decision to become a surgeon. I remember the day. It was I think some sort of old-fashioned varicose vein operation. I remember the surgeon exposed the groin, painted the betadine on the skin to disinfect it. Remember the bright big lights and the green drapes around the area. And then I remember the surgeon getting his bright, shining scalpel and making that first incision. And just as the blood sort of welled up, and I was thinking, well, I really want to do this. My medical school friend, this big Sikh guy called Sodi, collapsed all over the anesthetic tubing. So needless to say, I became a surgeon and he became a psychiatrist in the end. But that was my first, experience of the operating theatre, and I thought, well, I really would like to do that. So that was the road up to surgical interest.
I'm often asked, you know, what does a nice young man like yourself go into bowel and bottom surgery? And I have various stock answers for that. So I'll ask you the same. So why suddenly, or what made you want to become a bariatric surgeon specialising in weight loss
Yeah.
surgery?
So, well, when we were in medical school, obesity was not an issue in the 80s. So obviously it wasn't from there. It was sort of a bit fortuitous. So I had been training in laparoscopic surgery in my sort of senior years. I was quite good at laparoscopic surgery. I'm quite ambidextrous because I'm left-handed. I had this sort of background of playing too many video games when I was younger, so I had this sort of spatial
You mean
awareness.
as in keyhole surgery? I think some of our listeners may not be
Yeah,
so
keyhole,
medically qualified.
yeah, the laparoscopic or keyhole surgery. So I was training in that, and then I got a job at the Homerton Hospital. My first consultant job was at the Homerton Hospital, where they were doing bariatrics. So I basically learned on the job there. Quite a steep learning curve, quite difficult operations, but eventually managed to, do them quite safely. And then because there's pretty much a relative shortage of bariatric surgeons and a massive excess of patients, it sort of takes over your practice a bit. So probably about 80% of the work then became, from previously hernias and gallbladders to weight loss surgery.
And in your career up to now, have you noticed that there have been some big changes in weight loss surgery? What have been the main advances that you've seen in your lifetime?
I think the main one's got to be laparoscopic, because in the old days, people used to do weight loss surgery, the old-fashioned operation, through a big cut in the abdomen. And if you can imagine doing that on someone who's 20 or 25 stone, they're going to be in hospital for 2 weeks. They're going to have risk of thrombosis, chest infection. Afterwards, they may get a hernia through that wound. So actually, the introduction of this sort of doing the surgery through little keyholes, little cuts, 5 little cuts, just made it more doable. These operations take about an hour and a quarter. People stay in hospital for 1 night only, need a week off work because it's not that painful, and it's totally life-changing for them. So I think that is a big advance. More recently, I think the new hormonal treatment of obesity is something that, on the horizon is going to be more and more popular. So these are new drugs derived from hormones that originate in the intestines, so-called GLP-1 hormones, that actually work on the hypothalamus in the brain to affect satiety and appetite. And the new generations of these drugs, which are now a once-weekly injection, are for some people really, really effective in longer-term weight loss because they work hypothalamically.
So they work on the part of the brain that controls your desire to eat. Is that what you mean?
Yeah. So the hypothalamus is a part of the brain that controls a lot of our sort of subconscious activities. So a good analogy is, not only does it control and tell us how much to eat or when to eat and not to eat, but also our hydration system. So it has, very, very powerful hormones that can tell us that we're thirsty, and then we go out looking for water. So these are negative feedback systems that are within us that will, keep us at a particular hydration and weight that our bodies want. And it's very difficult to run away from those signals.
So I remember talking to you that my wife had a real go at me, and I stopped eating carbohydrates for about a month, and I lost a stone and a bit and felt very pleased with myself, and then sadly put it straight back on again. You've got quite strong theories about the fact that we're all born with a certain weight in mind. Is that correct?
Yeah, I mean, I didn't really know much about this until I started speaking to patients in bariatric clinics, so people that had been dieting for years and years and years and failing, and coming to me wanting me to remove their stomach or bypass their stomach. So quite drastic surgery. And from my limited training in medical school, I was sort of thinking, why can something so easy as just eating less and moving more, doing more exercise, prove so difficult that you come asking for this drastic surgery? So that inspired me, this sort of, thought that maybe we don't really understand what's going on and our patients are trying to tell us something. So yeah, I did 5 years of research looking into this area and came across the weight set point theory, which is gaining a lot of traction around the world to explain the difficulties of people, losing weight and sustaining weight loss. And basically that is explained by, we all have our own individual weight setting, which can be, obese or it can be slim. But it's determined a lot by our genes, but also by environmental or external factors. So that would be the type of food that we eat, not the amount of calories, but the type. And also our sort of stress responses, so the amount of sleep we get, whether we're really, really stressed at work or with family life or whatever. So all of these hormones that are altered by our diets, particularly insulin, but also our lifestyle, particularly cortisol, interact with factors in the hypothalamus that can push that weight setting up or down.
So
and
why
that's
is it
the basis of
when I was a sort of 28-year-old young man, I was a sort of an Adonis with a six-pack, and now I'm a sort of mid to late 50s individual. I've got a pot belly and I can't seem to do anything about it. What's changed in my, like, is it just that I'm happy, so I've let it all go, or does the set weight point change as you go through life?
I think as you go through life, I mean, as a sort of adolescent or young person who is not genetically massively predisposed to obesity, which I'm sure your family isn't, you're probably able to eat anything and struggle to put weight on.
Yeah.
But yeah, I think as time goes by, your metabolism isn't quite as dynamic, and maybe we get into more comfortable lifestyles where we eat a little bit too much sort of hedonic food, so sugary or refined carbohydrate food that makes us feel good. And it's not just the calories in that food that cause people to put weight on, it's the insulin that increases in your bloodstream and blocks this hormone called leptin, which is, the sensor to the hypothalamus about how much weight you have. So if that signal is being blocked, the hypothalamus gets confused and it thinks you don't have enough weight on board, so it wants you to eat more. So it's that sort of, those signals have profound effects on your weight set point. And this is why when you gave up bread and sugar and things, you, without counting calories, you lost, a stone, because suddenly your body was able to see the leptin, was able to see the fat signal and realize that actually, yeah, it's okay, we have enough energy on board. The analogy in the book is the gas tank, the petrol tank is okay, we have enough petrol on board. So that's why carbohydrates particularly can cause weight gain, not by the calories, but from insulin.
What's the secret, probably carbohydrate and sugar-free sauce that I can do to try and slim down a bit? I mean, so I've got thin legs, thin arms, but I've got a bit of, I think, what's known as centripetal obesity. Is there anything you can advise to help reduce that?
Well, a lot of men have, central obesity. You're not too bad, Richard. But a lot of men have a bit of a pot belly, and actually that's related a lot, I think, to cortisol. So the higher the stress, and this is a typical example would be a businessman, or a big boss in a corporation. They tend to be stressed all the time, not sleep properly, go on international flights, their sleep rhythm is disrupted totally, and this causes a distribution of weight in the same areas that if you were treated with hydrocortisone for a condition, you would lay down fat in centrally, like the potbelly of Cushing's syndrome.
Right.
So this is all to do with cortisol. I think that sort of central obesity affects men more than women.
And let's move on to your book. What made you want to go and write a book, and tell us how you went about doing it?
Well, going back to my first experiences in a bariatric surgery clinic, I hadn't been trained much in weight regulation in medical school. And the patients inspired me by saying, look, I can't do it. I've tried diets. I've tried what the dietitians have told me to do. I've tried counting calories. I can be on 1,200 kilocalories a day and lose some weight, but then eventually my body just catches up with me. And despite complying with the diet, I don't lose any more weight. So all of these questions inspired me to write the book. It really is inspired by those patients' stories.
And the book, as you know, is called Why We Eat Too Much, I believe, and it's available on Amazon and other platforms. Is that correct, Andrew?
Yeah, I've got a couple of...
You're going to show us a copy of it. That's great. Why
Yeah,
did you come up with the title "Why We Eat Too Much" as opposed to "How to Lose Weight" or that? Got it. Ah, good. Yeah.
Yes,
How did you come up with that title?
My idea for a title was Obesogenics. I sort of wanted to base it on the book Freakonomics, you know, this sort of alternative to look at economics. So I thought Obesogenics would be like a good, you know, title, but the guys at Penguin said, nah, people won't buy that. They won't understand that word. So they actually came up with the title Why We Eat Too Much, which I think probably was a good decision, actually.
And I mean, I have to say, I have read your book, and in fact, I bought a copy. You'd be pleased to hear. And I found the first sections of it very interesting, which looks into the science of why people are overweight, and some people are overweight, and some people are thin. You talk about tribes of very thin people and tribes of very large people. Can you give us a synopsis of the book, and perhaps tell us what the suggestions you made in the book were to help people?
So there's 3 sections in the book. The first section describes, you know, what goes on within our bodies, a little bit like what we've just explained. You know, the fact that it's not the calories, it's what the food and the environment does to the signals in our body that will adjust our weight up and down. We can set our weight set point. We can try and run away from that weight set point in the gym or starve ourselves away from it, but actually eventually our weight is going to get back to that. So the only way to address your weight is to understand those signals. And so they're to do with cortisol, insulin, and also a particular type of fatty acid, the omega-3 and 6 fatty acids, which have profound effects on our cells as well. So that's the first part of the book. The second section is a really interesting historical look at why we got to this sort of Western civilization that we built around ourselves with this sort of hedonic processed mechanized foods, rather than actually just having fantastic home prepared, you know, culinary foods and food cultures, how our food culture has gone away and been replaced by Western food culture. So it goes through all the way back from, you know, Stone Age men through to the science against saturated fat and the changes in dietary advice that governments gave populations. So that's the second part of the book. The third part of the book is sort of practical advice on how to adjust your weight point downwards long term.
Are you willing to reveal to us some tips on how to adjust our set points downwards?
Yeah, so basically it's not rocket science. The book looks into, you know, the effect of low calorie dieting, so starving yourself. That is really bad for you and will almost train your metabolism to become really, really efficient. Next thing you know, when you do get back onto normal eating, you actually put a load of weight on. So it explains that. But the things to do are to, I mean, the first part of the instructions says, give up where you can sugar-containing foods and refined carbohydrates like bread and pasta. If you can give those up, your weight setting will just automatically come down. The second advice is to try and decrease your cortisol level by sleeping better, decreasing the ambient light at night, which has a profound effect on your melatonin levels, which again indirectly affect cortisol, and to try and de-stress. The third advice is to try and take up an activity that you enjoy. Again, any type of physical exercise, it doesn't work directly by just burning off calories. Exercise improves the efficiency of insulin, so you need less of it. It also decreases your cortisol level. Again, both things acting indirectly to reduce your weight setting. And then finally, we also look into these omega-3 6 ratio. So throwing away vegetable oils, avoiding, you know, fast foods and processed foods that are in the pot or the pan or a jar for months on end. These are bad foods. Fresh foods will change that ratio, again, having a profound effect on your weight setting. And just finally, the last point would be to try and go lowish carb. on the general food that you eat, not go ketogenic, but lowish carb. And so there's an appendix in the book which actually looks into the glycemic load of all the different foods, common foods. So yeah, so none of it is rocket science, but it actually all makes a lot of sense. And there's so many confusing signals, dietary signals around. Do you go low fat? Do you go low carb? Do you go keto? You know, what happens if you're a vegetarian? All of these things are explained in the book. So yeah.
That sounds great. And can I, in terms of our society, do you think that obesity is become a problem in recent generations, or has it always been with us?
So if you go back to prehistoric times, there's figurines of massively obese, voluptuous women, but they would have had some very rare genetic disorder that made them obese despite a relative lack of food. The obesity epidemic started to really gain traction in the 80s when the governments did start to tell us not to eat saturated fat and instead to eat grains, whole grains. In fact, we didn't really eat whole grains. We had refined carbohydrates like white bread and pasta and things like that. So this profoundly affected, what the food does to our bodies. So yeah, it's been around for years, but the change in the type of food that we're eating in the last 30 years has had a profound, effect on the hormonal balance affecting our weight.
And if you were in charge, what measures would you take? Simple measures to for the whole population to manage to sort of drop their set points and lose some weight?
Well, for a start, I think education of exactly what is happening in the body, and that it's not all to do with calories. Obviously, calories are the ultimate, but actually the body controls the calories. So, you can't fight against the body. You need to adjust what the body wants in and wants out. And then once we have an understanding of that, I think people and governments would agree that, that these processed and fast foods are damaging the population's health, and indirectly the population's, finances. And so I would say that they should, think about taxing processed and industrialized and fast foods relatively heavily, and pouring the funds, the proceeds of those taxes into an education campaign, and maybe subsidizing fresh foods, like anything you get in a greengrocers or a farmer's market, and encouraging cooking as well. I mean, we've lost our food culture in this country, so many people can't cook. They have to go to Iceland and put chicken nuggets in the oven. So
you're looking at one, yeah. But so I've got, I'm really useless at that, I'm afraid, embarrassed to say. A couple of questions, just as we're running down with time. So, first one, if I was an up-and-coming registrar who was interested in doing bariatric surgery, would you encourage me to do it, or will it all be replaced with an injection or a tablet by the time I finally get to be qualified?
I mean, they are starting to discover excellent drugs that affect the hypothalamus, but I think bariatric surgery is going to be around for many years to come. But I think as far as just advice to become a surgeon is concerned, just hang around in the operating theatre. This is going to be your office. Listen to how surgeons are speaking, interacting with each other. Just, soak up that atmosphere of the operating theatre. If you like it, then just keep on persisting in this career path. If you don't really like it, then it's not the career for you. You should go and do another speciality. But I think that time in the operating theatre, even when it seems boring, people are talking, and if you soak that up, then when you come to the exam, you're going to know what you're talking about, and the surgeon examining you will know what you're talking about.
So get that full experience. And my second question is, just say that someone listening to us has decided that they're inspired by you and they want to write a book themselves. What advice would you give someone who wants to write a non-fiction book?
So I think you have to have this sort of unique idea or story. I was told by another author that I know called John Briffer, who's a GP, to just write like you would talk. Write like it's a story that you're telling someone. You don't have to be, Graham Greene or Ernest Hemingway or Shakespeare. You can do it. Just, you know, articulate your thoughts as you would say them. And I think so. Idea and write it like you would say it. And persistence. Obviously, when you have written the book, then you need to get a literary agent. It's all really, really interesting stuff. Yeah, and then you get a publishing deal, which is fantastic.
So had you arranged to have it published before you'd finished writing it, Andrew, or was it something that you wrote it and then you went out and they took it from you?
Yeah, it was really unusual in that I just wrote it. I had a very helpful medical director at UCLH called Richard Cohen, who gave me a year sabbatical. Thank you very much. Oh. Because I had all these ideas, so I just wrote the whole book. So the literary agents were like surprised, because normally they get like an idea in a couple of chapters. But I gave them the whole book, and they said, "Okay, yeah, this is pretty good." I had to alter a few things around, but yeah, I wrote the whole book and then went to a literary agent.
And it's got quite high up the charts, hasn't it? Where was it at its highest?
Got to #2 in the Amazon charts. It's actually still in the Amazon top 20, like a year and a half after publication. So top 20 most sold and most read nonfiction. So and it's doing really well in the audio charts. The audio narration is fantastic. Not by me.
And just do you think, are you going to have some spin-offs? Are you going to write a sort of abridged version, which is you know, just tips and tricks to get yourself back on a good.
You know, I'm waiting for that inspiration to come. It's got to be something. I want to write. If I wrote another book, it would need to be with some really good new ideas and things, rather than just a spin-off. Although a spin-off could be easy, and I'm sure I get an advance, but. Sounds good. I'm looking for inspiration.
So, Andrew, I'm really grateful to you for thinking about this and spending the time on our webinar today. Is there anything else you'd like to say to our? We have a very mixed audience of the public and some physicians and clinicians as well. Anything you'd like to say to them?
If you do have the time, then do consider. I'm not trying to sell. I don't get any money for the book, but I would advise trying to read the book, whether you're a patient struggling with obesity, someone who's just interested in this science, or a doctor. It's all of those levels are okay. It's like it's popular science, but actually, it's, you know, it would be really good for GPs and doctors to read. They'll pick up a lot about, you know, metabolic adaptation, this weight set point theory, leptin resistance, what happens in bariatric surgery, and you know how that's mimicked in the body. So, yeah. If you have time, read the book or
read it. No, thank you very much. And to everyone in the audience, we upload the recording of this webinar to the Cleveland Clinic YouTube site. So if someone says they'd like to hear it, or you'd like to hear it over again, it will be available out there in the not too distant future. And once again, I'd like to thank Andrew for his time, and I find it quite inspirational that one of my colleagues would actually sit down and write a book like he has, and I also know that he's a truly great physician and a great pair of hands, a great surgeon. So thank you very much, Andrew, and I will let all of you now go, and hope you all have a great evening. Thank you very much, and good night.
Richard, thank you very much.